students. So today we are going to discuss inflammatory bowel disease. Okay. So what is inflammatory bowel disease? Obviously, it means there is inflammation in the bowel. Okay. When we say inflammatory bowel disease, we mean two diseases. One is ulcerative colitis and another is Crohn's disease. Okay. Ulcerative colitis and Crohn's disease are together spoken of as inflammatory bowel disease or IBD. Okay. See, so what is the etiology of inflammatory bowel disease? Basically, nobody knows. It's an idiopathic condition, but it has genetic predisposition. That is, it has a genetic history. It runs in family, and there is an abnormal immune response or dysregulated immune response to the host intestinal microflora. Okay, the patient responds differently to the intestinal bacteria which is there, or intestinal microflora which is there. So it has genetic predisposition, and there is a dysregulated immune response to the microflora in the gut. It involves male and female equally. Basically, it's more common in 20 to 40 years of age group. Okay. So what about the symptom? How do these patients present to you? Usually they present to you with frequent bowel movement. Okay, it's odd bloody diarrhea, sometimes stool with blood, and it may be in mild cases less than 4 per day, 4 to 6 per day in moderate cases, or in more than 6, 7 or 10 times patient has to go to the toilet. Patient has got systemic symptoms like fever, not feeling well, weight loss, pain abdomen, etc. also in severe cases. So usually patient present to you with frequent bowel movement, blood in the stool, okay, and in severe cases with fever, weight loss, anorexia, etc. and some of the extra-intestinal manifestation. That is, it also involves other systems. Like in eye, you can have uveitis, epiascleritis. Some patients can have ankylosing spondylitis and ileitis, especially in HLA-B27 positive patients. In skin, you can have erythema nodosum and pyoderma gangrenosum. Okay, and these patients also can have primary sclerosing cholangitis, and there is increased risk of cholangiocarcinoma in these patients also can present with them. So these are the extra-intestinal manifestations of inflammatory bowel disease. What is the pathology? What will you find when you examine the slide or see under microscope? See, in ulcerative colitis, usually there will be inflammatory changes and mostly crypt abscesses. In the mucosal crypts, abscess occur. Crypts are distorted, crypt abscess occur, and there is loss of goblet cells and less of mucin in the goblet cells. This is characteristic of ulcerative colitis. Whereas in Crohn's disease, there is transmural inflammation. That is inflammation. Whereas in ulcerative colitis, inflammation is limited to mucosa, submucosa. There is loss of goblet cells and loss of mucin in them, and there is crypt abscess. Whereas in Crohn's disease, there is transmural. Whole thickness of the bowel wall is involved. There is non-caseating granuloma. The granulomas are seen in them. Okay, aphthous ulcers are seen, and these aphthous ulcers can become very deep ulcers, and in between the mucosa gets an appearance of cobblestone mucosa. Okay, we call it cobblestone mucosa. So Crohn's disease is a transmural inflammation with granuloma and inflammatory cells. Ulcerations are there, cobblestone mucosa will be there, and whereas in ulcerative colitis, inflammation is limited to mucosa, submucosa. Okay, see, ulcerative colitis usually starts in the rectum, okay, and it then ascends upwards. First it involves rectum, then it ascends and involves the a sigmoid colon and descending colon. That is when it involves only sigmoid and rectum, we call it proctitis, rectal ulcerative proctitis, or if it only rectum is involved. If the left colon is involved, left-sided colitis might involve the whole colon, in which case we call it pancolitis, ulcerative pancolitis. Whereas Crohn's disease can involve anywhere from oral cavity to anal canal. Okay, anywhere from oral cavity to anal canal. And the other characteristic of Crohn's disease is that there is skip lesions, means a lesion occurring at one part of the GI tract, then a normal mucosa, normal gut is there, then on another part there will be another lesion. Okay, so Crohn's disease mostly occurs in the ileocecal region. Very common site is ileocecal region, and you will find that one part is involved, then another part is normal, and then again another part is involved. This is characteristic of Crohn's disease. Whereas in ulcerative colitis, it almost always starts in the rectum, and then there is a contiguous spread. There is no skip lesion here in ulcerative colitis, which you get in Crohn's disease. So this is the difference between ulcerative colitis and Crohn's disease. To summarize again, ulcerative colitis begins from the rectum and then involves the adjacent colon, left side, then the whole colon. The inflammation is limited to mucosa, submucosa. Okay, and here in the chronic ulcerative colitis, if you do a barium enema, it will look like a hose pipe, straightened and shortened pipe-like structure. Whereas Crohn's disease can occur anywhere in the GI tract. It does not begin in rectum. Most commonly it occurs in the ileocecal region. Usually skip lesions are there. Whole bowel wall is involved. Transmural involvement is there. Granular formation is there. And the perianal involvement, fissure, fistula and perianal involvement is more common in Crohn's disease. Okay, not in ulcerative colitis. So this is the difference between ulcerative colitis and Crohn's disease. How do you investigate such patients? Usually we do a colonoscopy on them. In colonoscopy, if it is ulcerative colitis, you will find that rectal mucosa is hyperemic, inflamed, there is loss of vascular pattern, the mucosa bleeds on touch. In severe cases, there will be even blood in the lumen. Okay, and as you proceed, you might see that left colon is involved or the whole colon is involved. Okay, this is whereas, and you can take biopsy, which will show there is crypt abscess and cryptitis and all, and inflammation limited to mucosa, submucosa. In Crohn's disease, usually I said it involves ileocecal region. It can involve anywhere, and skip lesions are there. So it's difficult to diagnose. If a colon is involved, fine, you can see by colonoscopy. Otherwise, we'll have to do a capsule endoscopy in these patients. A special capsule patient ingest, which transmits, which has got camera, which transmits images, which is seen on the computer, and it travels along the whole of the GI tract and send images, and the images are seen and interpreted, and you can see some inflamed part of gut is there. Okay, so this is and gut is there, which is suggestive of Crohn's disease. So this is how you do a flexible sigmoidoscopy, colonoscopy, or capsule endoscopy in cases of Crohn's disease, and you do blood test. Of course, complete blood count, which will show if patient has blood anemia, isn't it? And another, in feces, we see fecal calprotectin. Fecal calprotectin is a marker which shows that there is inflammatory bowel disease or inflammation in the bowel. Raised level of fecal calprotectin suggests inflammatory bowel disease. Okay, you can also measure ESR and C-reactive protein. These inflammatory markers will be obviously raised in inflammatory bowel disease. Okay. What are the complications which can occur because of inflammatory bowel disease? See, these patients can bleed, and an ulcerative colitis, severe bleeding can occur. Sometimes toxic megacolon occur, in which colon becomes grossly dilated, and even it can perforate. So there can be severe bleeding, toxic dilatation of colon can occur, perforation can occur. Okay, in Crohn's disease, usually there is stricturing. stricture in formation is there, because transmural inflammation is there. So multiple strictures can occur, and patient can present with intestinal obstruction and vomiting and hematochezia and all. Okay. So these are the complications of this disease. So how do we treat inflammatory bowel disease? What we do, first we put them on conservative treatment. If it is mild disease, oral treatment. Oral treatment, mainly it is for both ulcerative colitis and Crohn's disease, 5-amino-salicylic acid. 5-amino-salicylic acid derivatives like sulfasalazine, mesalamine, azacol, etc. are given orally. Okay? These are also can be given as a suppository form. If only rectal involvement is there, as in ulcerative colitis, rectal enema of 5-amino-salicylic acid derivatives can be given. Suppository can be given, enema can be given. Okay. So 5-amino-salicylic acid, sulfasalazine is the mainstay of treatment. You can also give, in severe cases, we add corticosteroids. Prednisolone, methylprednisolone can be added, okay, to give relief in these patients, which acts as an anti-inflammatory in both ulcerative and Crohn's disease. If that doesn't work, then third modality of treatment is immunosuppressant or immunomodulators can be given. Azathioprine, methotrexate, azathioprine are used in ulcerative colitis and Crohn's disease. And sometimes antibody against tumor necrosis factor, infliximab is used in those cases which are resistant to these treatment. Then antibodies against tumor necrosis factor, infliximab infusion can be given in these patients. So this is how you treat 5-amino-salicylic acid, corticosteroids, then you have azathioprine, methotrexate, then you have tumor necrosis factor antibodies like infliximab, and these can be used for treatment. If a severe infection is there, you can admit the patient and give hydrocortisone IV to these patients, okay, and fluid and electrolyte balance is maintained. Okay. See, so this is how we treat the ulcerative colitis and Crohn's disease. Then what are the indications of surgery in inflammatory bowel disease? Indications of surgery obviously is if there is failure of medical treatment. This medical treatment is not working, patient is taking them for months together but not working, then that's an indication. Or patient has become steroid dependent. All the time you have to give steroid to these patients, so that's also an indication for surgery. Or some of the complication has occurred, which I have told, like toxic megacolon, perforation, severe bleeding, obstruction has occurred. Then, and you see, ulcerative colitis is also an increased risk factor for colonic carcinoma. If a long-standing ulcerative colitis for more than 10 years increases the risk of adenocarcinoma of the colon. So, if there is risk of malignancy, neoplastic change has occurred, then it is also an indication for surgery. So, what surgery you do? Or if extraintestinal manifestation is very prominent, uveitis, iridocyclitis, or ankylosing spondylitis, that's also an indication for surgery. Okay, so failure of medical treatment, steroid dependency, complications, malignancy, extraintestinal manifestations, these are indications for surgery. Then what surgery you do? In ulcerative colitis, as you know, the whole colon is usually involved. The treatment will be total proctocolectomy with permanent endoleostomy. And if patient doesn't want endoleostomy, all you can do is total proctocolectomy with ileal pouch anal anastomosis. That is, ileum is made into a pouch, J-shaped or W-shaped, and anastomose to the anal canal. This is called restorative proctocolectomy with ileal pouch anal anastomosis. Okay, so these two options are there. And in Crohn's disease, usually small bowel is involved in part of it, so segmental resection can be done. Or if it is limited strictures are there, stricturoplasty can be there, where longitudinal incision is given and it is stitched transversely. So stricturoplasty can be done in some cases, otherwise segmental resection has to be done. Okay, so this is how you treat ulcerative colitis and Crohn's disease.